तुमने कर लिया ज्वाइन, देखो कैसे लग रहे हैं सर।
Hello. हाँ फिरोज सर।
जी जी जी
यहाँ से स्टार्ट।
अच्छा शुरू कर लें
जी।
Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning. Welcome to our second national webinar on Ilmul Jarahat Updates 2022. I am your host, Dr. Firdaus Ahmed Najjar, convener of today's program. I have with me two my co-hosts, Dr. Muhammad Shakil Ansari and Dr. Mahjubin Fatima, organizing secretaries of this program. Professor Saeed Shah Alam, Chairman, Organizing Committee, and we are working under the patronage of our Director, Professor Abdul Wadud. Am I audible?
Yeah.
Dear participants, today's webinar is also a part of the celebrations of Azadi Ka Amrit Mahotsav. In our last webinar in March 2022, we had two lectures on laparoscopic procedures and laparoscopic instruments. Today's program will cover two different topics. The schedule of the program will be as like welcome address, welcome.
सर म्यूट हो गया है।
म्यूट हो गया। हेलो।
तो सर म्यूट करो अपने आप।
अलम फिरदौस भाई म्यूट हो गया है।
जी जी हाँ यस 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 हाँ हेलो
हाँ ओके
okay. We have received immense response in our last webinar and appreciation from our participants. Today's program will cover two different topics. And the program will consist of our welcome address followed by two lectures. After every lecture, enough time will be given to the participants for interaction with the speakers. The program will end by the vote of thanks. Dear audience, today's first lecture is non-healing ulcer and its management. As you know that non-healing ulcers do not proceed towards healing in a defined time period. These ulcers affect about 1.6% of adult population and 3.6% of the elderly people, and ultimately leading to the amputation, disabilities, rehabilitation, and putting an economical burden on the society. Many almost participants have joined us. We will take this opportunity to welcome all the participants. And for welcome address, I will invite our HOD and Chairman Organizing Committee, Professor Syed Shah Alam, to welcome the participants. Professor Syed Shah Alam.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am thoroughly pleased to witness you all here. It is a moment of extreme pleasure to welcome the guests who are present here to attend this one-day national webinar as a part of celebration of Azadi Ka Amrit Mahotsav. On the behalf of organizing committee, I welcome to all the participants who joined today one-day national webinar on Ilmul Jarahat updates 2022, particularly our director, Professor Abdul Wadud sir. I bid a very warm welcome to today's speaker, Dr. Minhaj Ahmad, Associate Professor, School of Unani Medical Education and Research, Jamia Hamdard. He is the first Unani surgeon and serving as a medical superintendent, Hospital Sumer, Jamia Hamdard, and Dr. Mahjabeen Fatima, Assistant Professor, NIUM, Bangalore. She is a dynamic, efficient surgeon and clinician and academician as well. And I welcome all our teachers, faculties, colleagues, and students who have joined. We all have gathered here today to attend this one-day national webinar based on enhance our knowledge. This series of webinars intend to resolve the particular hurdles faced by the doctors and practitioners. Today's webinar will cover two important topics on non-healing ulcer and its management, and hemorrhoids and its management. Both these ailments can be damaged by different available treatments. This webinar will enlighten us that how and when these are manageable. Therefore, I am sure this webinar will be meaningful and thought-providing and useful to all the participants. I once again welcome one and all who are with us. Without any further delay, I would like to start this event. We would be delighted to have your suggestions and questions at the end of the event. Thank you all of you again, and welcome all of you one and all again. Thank you.
Thank you. Thank you, sir. Dear participants, we were talking about the non-healing ulcers. As you know, you are well aware that the term coined in our literature is delayed healing ulcers. Non-healing ulcer term is coined in conventional medicine. How these ulcers occur and what different treatments are available in different system of medicines will be elaborated in detail by our first speaker, Dr. Minhaj Ahmad, who is Associate Professor, School of Unani Medical Education and Research, Jamia Hamdard, New Delhi. I am proud to share that he is the first Unani surgeon of our country. He has done his BMS and MS from Ajmal Khan Tibiya College, Aligarh Muslim University. Soon after completing his master's, he joined Jamia Hamdard in 1999. He has headed the department as chairman, Department of Jarahat, Jamia Hamdard. Currently, he is Deputy Medical Superintendent of the attached hospital of Jamia School of Unani Medical Education and Research, that is Majidia Hospital. He has attended and presented papers in 124 national and international conferences and seminars. He has around 50 publications to his credit. He has also authored and co-authored 2 books. He has received 2 awards, Young Scientist Award and Excellent Teaching Award also. Dear participants, besides this, he is a polite person, a good teacher, a good clinician, a good surgeon also. Let us invite Dr. Minhaj Ahmed for his talk. Before starting his talk, I request participants to mute yourself. You will be given time for interaction with the speaker at the end of the lecture. Over to Dr. Minhaj Ahmed.
Thank you, Dr. Firdaus, and your team, organizing
welcome.
team,
Welcome, sir.
for giving me opportunity for the deliberation on the topic of non-healing ulcer and its management. Once I want to share my screen. Can you see my presentation?
Yes, sir. Yes, sir.
It is partially hidden or completely visible?
No, sir. It is completely visible.
Completely. Okay. Here in our screen, there is partially covered by your pictures. So I want to adjust it. Okay.
Slide presentation just need. Slide presentation.
Wait, 1 minute, 1 minute.
So you minimize these pictures. You can minimize them.
Hmm?
You can minimize them.
Okay. ये जरा देख ये मिनिमाइज कैसे होगा? अच्छा हाँ यहाँ से हो जाएगा. ओके ओके ओके. ठीक है. ओके. हेलो.
Yes. Yes, sir.
जी, अस्सलाम वालेकुम व रहमतुल्लाहि व बरकातुहू. A very good morning to all of you. Today I am going to present non-healing ulcer. Here also some problem. एक मिनट देखना, ये क्या आ रहा है? ये ऊपर कैसे आ रहा है? इसको नीचे कर, नीचे. हाँ, और नीचे, और नीचे नहीं जाना. कैसे कैसे
Anal bhai, your physical screen is okay, no problem. You can start.
बिकॉज ये थोड़ा सा हिडन हो रहा है. हमारा एक बेल्ट सी, एक पट्टी सी आ रही है नीचे, पता नहीं क्या है ये.
But in our screen it is okay.
ओके.
एस्केप कर लीजिए. एस्केप करके
अच्छा.
हाँ, देख लीजिए. उसके बाद
करो.
Your slide is okay. Anal bhai, it is visible clearly, no problem.
No, but my slide will be hidden here. I face problem. Okay, no problem. Okay. Yeah, sorry for delay, and there is some technical problem, you know. Bismillahir Rahmanir Rahim. Now I am going to present non-healing ulcer and its management, which is a very burning topic and very complicated topic for the in the line of management. Slide क्यों नहीं चल रही? चल नहीं रही है slide हमारे. हाँ आई okay. Ulcer. As ulcer as a whole, an ulcer is a break in the continuity of covering epithelium, skin or mucous membrane due to molecular death. एक जनरल डेफिनेशन है जिसमें सारे अल्सर्स आते हैं, बट आज का टॉपिक जो कि नॉन हीलिंग अल्सर है उसके रिगार्डिंग हम बात करेंगे. नॉन हीलिंग अल्सर, नॉन हीलिंग अल्सर और अल्सर which do not heal by conservative therapy within 6 weeks. And also there is some differences in literature. A range of 4 weeks to 3 months also has been mentioned in the literature. तो ये ऐसे थोड़ा सा इख्तलाफात हैं इसमें, बट यूजुअली हम इसे मानते हैं कि 6 वीक तक अगर कंजर्वेटिव ट्रीटमेंट के बाद भी ठीक नहीं होता तो that is coming in non-healing ulcer category. Epidemiology: 1 to 2% of population in developed countries will suffer from a chronic wound or a chronic or non-healing ulcer. Chronic wound or ulcer affect approximately 2 to 6 million patients in United States per year. Patient with chronic wound may experience the following: chronic pain, loss of function and mobility, increased social stress and isolation, depression and anxiety, prolonged hospitalization, increased morbidity and mortality, increased financial burden on society. ये सारी चीजें एक ऐसे पेशेंट में जो नॉन हीलिंग का सफरर है उसमें देखने को मिलेगी, उसको होगी. पार्ट्स ऑफ एन अल्सर, मकसद सिर्फ ये है कि इससे ये जाना जाए कि किस तरह का अल्सर है और हमें डायग्नोसिस में इससे हेल्प मिलेगी. तो देयर आर 4 पार्ट्स. अल्सर को 4 हिस्सों में डिवाइड किया जाता है, 4 पार्ट्स में, मार्जिन, एज, फ्लोर और बेस. और इस पिक्चर में आप इसे देख सकते हैं कि मार्जिन, इट इज सराउंडिंग द अल्सर, एज between margin and floor which is exposed part of the ulcer, base which cannot be seen but can be feel. Different ages of ulcer, जो in general हम जब किसी अल्सर्स के बारे में जब हम बताते हैं तो उसमें ये चीजें मेंशन की जाती हैं कि स्लोपिंग एज, punched out एज, अंडरमाइंड एज और रेज्ड एंड बीडेड एज, इवर्टेड एज. ये अल्सर के डिफरेंट एजेस हैं और इससे हम अल्सर्स की डायग्नोसिस में हेल्प लेते हैं. क्लासिफिकेशन ऑफ नॉन हीलिंग अल्सर. Wound Healing Society classifies chronic ulcer in 4 major categories: pressure ulcer, diabetic foot ulcer, venous ulcer, arterial insufficiency ulcer. तो इन्हीं 4 कैटेगरीज में से कोई ना कोई कैटेगरीज होंगी जो नॉन हीलिंग अल्सर प्रेजेंट करेंगे. Factors affecting wound healing and contribute to the pathogenesis of chronic wounds or ulcers are infection, ischemia, metabolic condition, immunosuppression, radiation. ये pathogenesis of chronic ulcer में contribution होता है इनका, और particularly during the treatment we have to focus on these factors. In detail थोड़ा सा हम इसके बारे में बताएंगे कि infection क्या करता है. What is the role of infection in non-healing ulcer? The infection interrupts process of wound healing, inhibits the inflammatory phase of epithelialization, increase in local inflammation response, and prolonged acute inflammatory phase. Presence of infection causes presence of necrosis tissue, prevents ingrowth of new tissues. Necrotic tissue act as a culture medium for bacterial proliferation. Foreign body also invite infections such as stitches, abscess, non-absorbable suture materials, infected surgical mesh, retained blood. ये सारे फैक्टर्स ऐसे हैं जो इन्फेक्शन को इनवाइट करते हैं और इसके नतीजे में हीलिंग डिले होती है. Ischemic conditions that result in chronic non-healing ulcer can be seen in arterial insufficiency, venous hypertension, pressure injury. इनमें से कोई ना कोई फैक्टर होगा जो नॉन हीलिंग अल्सर के लिए सबब बनेगा, कॉज बनेगा. Ischemia due to arterial insufficiency, how it occurs, कैसे इसका रोल क्या है, थोड़ा सा इसके बारे में. Arterial blood flow to the tissue diminish. अगर ischemia हो, उसके नतीजे में क्या होगा? Decrease in the delivery of oxygen and nutrients to the wound, impairment in the removal of metabolic waste product from the wound, rest pain in extremities due to insufficient blood supply to meet the metabolic demands of the tissue, clinically shiny skin with paucity of hair. The metabolic demands to maintain intact skin is higher than the metabolic demand to heal an ulcer. तो एक अल्सर को हील करने के लिए जो डिमांड होती है, मेटाबॉलिक डिमांड, उससे कहीं ज्यादा डिमांड होती है इंटैक्ट स्किन को इंटैक्ट रखने में. The most common cause of arterial insufficiency ulcer is obstruction of large and medium size of arteries, which is usually caused by atherosclerosis. Some other conditions also that affect small arteries, such as vasculitis, thromboangiitis obliterans, scleroderma. These are also affect on the small arteries and cause arterial insufficiency, ulcer, wound. The next one is ischemia due to venous hypertension. Venous hypertension may cause ischemia to the tissues, skin. The cause of venous hypertension are chronic deep vein thrombosis, arteriovenous fistula, venous insufficiency. All these result in capillary leakage and decreased oxygen permeability, hypoxia to the tissue, impaired healing of ulcer. Loss of pressure gradient between the arteriole and venules leads sluggish movement within the capillaries, result in capillary leakage. Ultimately, ischemia develop होना है. Capillaries of patient with venous stasis are also occluded in the turn, reduce oxygen and nutrition to the tissue, predisposing to ulcer formation. So these are certain causes of venous ischemia. Ischemia due to pressure injury. Pressure बहुत common होता है, उनके नतीजे में होता है. This is caused by combination of pressure and shearing force. दोनों force होते हैं इसमें, जिसकी वजह से pressure injury develop होती है. Bony prominence are at high risk. Yes, the high risk bony prominence, the sacrum, heel, occiput, shoulder blades. Pressure to the skin more than arteriolar pressure lead to cut off oxygen and nutrient supply to the tissue. And a pressure more than 70 millimeter of mercury for 2 hours result in variable tissue loss. Continuously अगर 2 घंटे के लिए प्रेशर हो और वो भी 70 मिलीमीटर मर्करी से ज्यादा हो, तो उससे टिश्यू इस्कीमिया होगा और उससे अल्सर डेवलप होगा. Patient in lying position on a standard mattress can produce a pressure of 150 millimeter mercury. And while patient in sitting position on general can generate a pressure of 300 millimercury over the ischial tuberosity. तो इतना डिफरेंस है बैठ करके रहने में और लेटने में, और दोनों तरीके से देखा जाए तो ये 70 mm से ज्यादा है, मिलीमीटर ऑफ मरकरी से ज्यादा है. Clinical evaluation of pressure injury is challenging. बड़ा मुश्किल है. We cannot measure properly by any instrument. Moisture from perspiration, urine, feces can lead to maceration and superficial tissue injury. These are few examples of how much they damage gradually. There are certain staging system which I will discuss in later slide. Third one is the metabolic conditions. Metabolic conditions that contribute to develop of non-healing ulcers are diabetes mellitus and malnutrition of any type. Diabetes mellitus, I will discuss in detail in next slides. Malnutrition also. Diabetes mellitus, high glucose level in the tissue provides medium for infection. Diabetic microangiopathy causes hypoxia. Neuropathy, sensory and motor neuropathy leads trauma and infection. Diabetic atherosclerosis, these are the factors which causes pressure or diabetic ulcers. Micro and macrovascular diseases and diabetes result in tissue ischemia and delay healing. Autonomic neuropathy, decrease in autonomic tone and vessels, shunting of blood from the arterioles directly to the vein bypass the tissue required nutrients. तो पहले ही शंटिंग हो जाती है, ये एंड तक नहीं पहुंचाते, स्किन तक नहीं पहुंचते, जिसकी वजह से टिश्यू नेक्रोसिस होती है. मालन्यूट्रिशन में प्रोटीन खास होती है, तो प्रोटीन डेफिशिएंसी प्रोलॉन्ग इन्फ्लेमेटरी फेज, डिले वुंड हीलिंग, required for the proliferation of the fibroblast, required for the improvement important immunologic functions such as phagocytic activities of macrophages, T cell functions, antibody production. Malnutrition increases risk of wound infection. तो ये सब के सब मिल करके एक ऐसा माहौल क्रिएट करते हैं स्किन के अंदर जिसकी वजह से वहां पे इस्कीमिया होगा और अल्सर बनेगा. इम्यूनिटी का बहुत बड़ा रोल है जो हीलिंग में कंट्रीब्यूट करती है. The immunosuppression contribute to the development of non-healing. Protein deficiency, immunodeficiency, तो उससे wound healing. Corticosteroid interfere with the major steps of the wound healing process. Corticosteroids decrease the expression of cytokines that are responsible for the recruitment of inflammatory cell in the inflammatory phase. And otherwise, radiation, repeated radiation is practically seen that they will cause delay healing. Ionized radiation cause delay in the wound healing. Radiation injury results in chronic non-healing wounds. Apoptosis and cellular necrosis also cause radiation by radiation. Luminal thrombosis and obstruction in repeated and multi-time X-ray and radiological treatment. Signs and symptoms means I will start from the history. We have to take the detailed history of an ulcer and to know the causative factors and treatment strategies. उसके लिए हमें डिटेल हिस्ट्री होनी. अल्सर हिस्ट्री के टाइमिंग एंड ऑनसेट, क्वालिटेटिव चेंजेस, प्रीवियस ट्रीटमेंट, सीवियरिटी ऑफ पेन, प्रायोरिटी वुंड इफ एनी, तो इनके बारे में हमें जानना है. इसी तरह से मेडिकल हिस्ट्री जिसमें डायबिटीज मेलाइटस, पेरिफेरल आर्टेरियल डिजीज, वेनस इनसफिशिएंसी, रिसेंट वेट लॉस, स्मोकिंग, रेडिएशन, इम्यूनोसप्रेशन, ये सारी चीजें हमें जाननी है, मालूम करनी है, हिस्ट्री लेनी है, इससे हमें ट्रीटमेंट में बेनिफिट मिलेगा। प्रीवियस सर्जिकल हिस्ट्री रिलेटेड टू द ट्रीटमेंट ऑफ द अल्सर, कि वुंड डिब्राइडमेंट हुआ कि नहीं हुआ, स्किन ग्राफ्टिंग, आर्टेरियल रिवास्कुलराइजेशन, वेन एब्लेशन प्रोसेस। तो ये सब चीजें कंट्रीब्यूटिव फैक्टर्स हैं। फिजिकल एग्जामिनेशन में ये तीन चीजें बहुत ध्यान से हमें रखनी है, ध्यान में रखनी है कि इसी पे हमारा ट्रीटमेंट डिपेंड करेगा कि कैसे करना है। Ulcer assessment, vascular assessment, neurological assessment, ulcer assessment, location, number and characteristic of ulcer, dimension. मैं थोड़ा सा इसलिए फास्ट कर रहा हूँ कि बहुत ज़्यादा टाइम नहीं है, इसमें बहुत सारी स्लाइड्स हैं हमारे पास, तो मैं थोड़ा फास्ट करना चाह रहा हूँ। Dimension and volume of the ulcer should be recorded. Healing potential, photography, ताकि इससे हम कंपेयर कर सकें कि पहले क्या था, अब बाद में क्या हुआ। असेसमेंट ऑफ साइन ऑफ इन्फेक्शन, साइन ऑफ इन्फेक्शन ये सारे हैं जो यूजुअली मिलते हैं कि इंक्रीज ब्लैंचिंग रिथमा सराउंडिंग द अल्सर, इंड्यूरेशन सराउंडिंग ऑफ द अल्सर, लिम्फेंजाइटिस, वुंड ड्रेनेज, फाउल ऑर्डर, इंक्रीज टेंडरनेस, इंक्रीज वार्मथ, फीवर, ये सारे साइन है। वास्कुलर असेसमेंट, थिनिंग ऑफ द स्किन, जिसे हम देख करके अंदाजा लगा सकते हैं फिजिकल एग्जामिनेशन में। नेल बेड, ब्रिटल, हाइपरट्रॉफिक एंड रिजिड, cold skin, Burgess test will positive, pink and perfuse skin in normal individuals, limb will be pale in ischemic condition, ischemic pain with leg elevation. न्यूरोलॉजिकल असेसमेंट में ये वाइब्रेशन सेंसेशन बाय ट्यूनिंग फॉर्क का इस्तेमाल करते हैं, जिससे हमें पता लग जाता है। और इसमें खास चीज़ ये देखनी कि ट्यूनिंग फॉर्क को जब उस सेंसेशन के लिए टेस्ट करते हैं तो उसमें ये जानना ज़रूरी है कि जब ट्यूनिंग फॉर्क उसको रखा जाए तो उसका एहसास हो वाइब्रेशन का और एंड का भी, सेंसेशन का भी। द पेशेंट रिपोर्ट्स बोथ स्टार्ट ऑफ वाइब्रेशन एज वेल एज cessation. In normal individual, it is same. Pressure sensation test, superficial pain sensation test, ये चीजें हमें करनी होगी to know the ulcer. The perform using इसके तरीके हैं, इस पे ज्यादा डिटेल में नहीं जाते। क्लिनिकल फीचर ऑफ नॉन हीलिंग अल्सर, इस पे आते हैं। हाँ, there are different type of ulcer. ये क्या आ रहा है इस पे? Who is making some change on the slide?
डॉक्टर एम आलम जो है, आप लिख रहे हैं स्क्रीन पे कुछ, आप प्लीज स्टॉप करें इसको।
तो प्रेशर अल्सर, प्रेशर अल्सर common in hospitalized persons due to stroke or paralysis, prevent from them from the feeling of the pressure or movement. Bedridden patients are at high risk, develops on skin and soft tissue overlying bony prominence, तो खास तौर से common site sacrum, ischial tuberosity, calcanea, medial and lateral metatarsal heads, fibula head. These are the stages of pressure ulcer. You know, the most common used staging system in the United States is the National Pressure Ulcer Advisory Panel classification system. The stage 1, non-blanching erythema and intact skin. The stage 2 may there will be partial thickness skin loss with exposed dermis. And in stage 3, full thickness skin loss. And in stage 4, full thickness skin and tissue loss. And the unstageable pressure injury also obscure full thickness skin and tissue loss completely. There are some examples. You can see that the first stage there is in both phase, and second stage it involves the skin, total skin and subcutaneous tissue, and third stage whole the skin and tissue up to the bone, and here in the fourth stage bone also affected. Unstageable pressure injury, there is, we cannot say any stage, but it involves the bone also. Diabetic foot ulcer commonly occurs in location of repeated trauma and metatarsal hair. Callus formation in the area of the ulcer with associated undermining of the borders, punched out appearance. You can see in picture the loss of vibration, pressure or pain sensation are indicated of peripheral न्यूरोपैथी. तो डायबिटिक फुट जैसा कि हमने उसमें बताया था, डायबिटिक फुट अल्सर में भी क्या होगा, सेंसरी लॉस भी होता है इसके अंदर. इसीलिए venous ulcer. Venous ulcer are located between the knee and ankle. Dull ache and swelling relieved by elevation of the limb. History of recurrence of ulcer in the same area. Shallow and irregular edges of the ulcer. And granulation tissue, red granulation tissue. The skin surrounding the ulcers is eczematous, reddish, brownish, hyperpigmented. Dilated tortuous superficial veins are very supportive for the diagnosis. Arterial insufficiency ulcers, symptoms of claudication or rest pain depending on the severity. Rest pain may be aggravated by elevation of the extremities and relieved by the dependent position. Ulcers are typically in the most distal part of the toe, floor pale, gray, or yellow, unhealthy granulation tissue. So you can see in this picture also. There are some laboratory tests which can help, but usually we clinically diagnose the ulcer. But for the support and for the purpose of treatment, we have to see the diagnostic test also. The serum marker of inflammation, white blood cells, C-reactive protein, erythrocyte sedimentation rate, HbA1c, a renal function test, albumin, and total lymphocyte count should be evaluated. Imaging studies for the patient with a suspicion for osteomyelitis, X-ray. You can see there's a periosteal thickening in the X-ray. CT shows changes earlier than the conventional radiograph. MRI is highly sensitive for the detecting of osteomyelitis. So the best test is the MRI. You can use MRI to see the osteomyelitis beneath the ulcer. Treatment strategies for the pressure ulcer. We have to make any strategy to properly diagnose the case and to properly treat the case. Reduce underlying contributory factor for pressure ulcer, repositioning of the patient every 2 hours, use foam mattress or air beds, physiotherapy to help elevate their immobility status, treat systemic infection, maintain nutrition. Usually stage 1st and 2nd ulcer prevention and local wound protection requires. But stage 3 and 4 focus on local wound debridement. Delayed closure, skin grafting, psychosocial support to the patient and their families. Now you see the treatment strategy for the diabetic foot ulcers. You have to treat the contributory factors. The contributory factors such as infection, neuropathy, ischemia should be treated. Debridement of infected wounds, systemic antibiotics, revascularization in arterial insufficiency, reduce pressure on the ulcer by mechanical offloading, refer to foot and ankle specialist in foot deformities cases. Close up, close follow-up, and recurrence prevents strategies should be adopted for diabetic ulcer because there is recurrence chances are more. Now, the treatment strategies for the venous ulcers, that The primary objective is to enhance the venous blood flow. कोई भी तरीका अपनाए, चाहे वो मैकेनिकली हो, फार्माकोलॉजिकली हो, उसे हमें इनहांस करना है. और leg elevation above the heart
हेलो मिनाज भाई, ऑडियो.
हाँ, हेलो, आवाज नहीं आ रही है.
नहीं, उनका नेट चला गया. नहाज भाई का नेट चला गया है.
उनका पॉज हो गया है.
हाँ.
एक बार फोन पे बात कर लीजिए शाम सर.
शानम भाई फोन कर लीजिए नहाज भाई को.
उनको पता नहीं.
भाई अस्सलाम वालेकुम.
हाँ, हो गया, उसकी बात होगी, बस होने वाला है.
Speaker is connecting back in a while. Dear participants, please wait.
भाई अस्सलाम वालेकुम.
Am I audible?
Yes. Minaj bhai?
Yes.
Yes.
Okay.
Go ahead.
Screen is visible.
No, sir. Share your screen,
No.
please.
Can you
Okay.
again share the screen? Yeah.
Okay. Share. Okay.
Yes. Yes.
Okay. Sorry for disturbance.
Oh, sorry, it's technical problem. No.
Yeah.
Naj bhai, वो downside, touch it. Downside, yeah.
Is it clearly visible?
Yeah. Start.
Sorry for disturbance. Yes, I continue. The treatment strategy of venous ulcer. I was talking about that. The wound dressing depend on the level of exudates and wound, skin moisturizer for the dry itching and eczematous changes in the skin of the lower limb. Topical corticosteroid can be used for the skin. इसके लिए जरूरी है कि अगर कुछ इस तरह की चीजें आती हैं वहाँ पर पिगमेंटेशन है तो उसके लिए मॉइस्चराइजर यूज किया जाए. Treatment of varicose vein on priority basis such as saphenous vein ablation, interruption of perforated vein stripping, sclerotherapy. Treatment strategy for the partial arterial insufficiency ulcers, restore blood flow by any means, revascularization, endovascularization. Endovascularization करें या जैसे भी हो, revascularization करें, उससे restore vascularization phase, revascularization extremities for the dry gangrene and non-infected treatment. जब भी डिब्राइडमेंट करना होगा उससे पहले बेहतर है कि उस एरिया की ब्लड सप्लाई को मेंटेन किया जाए और नॉर्मल हो जाए. For wet gangrene, the wound should be immediately debrided क्योंकि इससे दूसरे कॉम्प्लिकेशन होंगे. Revascularization after infection control, delayed wound closure, once blood flow restored, remove risk factors such as smoking and other factors which contribute in this condition. You can see here, after revascularization, the wound, and previously it was the wound, such a big wound, but after revascularization, there is a drastic change and the wound is gradually healed. Basic principles of wound care management. For the proper healing, the ulcer should be free from infection, free of necrotic tissue, adequately perfuse, moist. तो वुंड के कैरेक्टर ये होने चाहिए कि उसके अंदर इन्फेक्शन नहीं हो, ये सारी चीजें ना हो, तभी वुंड हीलिंग हो सकती है. Wound care with debridement and proper wound dressing will promote granulation tissue formation, epithelialization, primary closure of the skin grafting done after granulation and epithelialization would help in the healing. Wound debridement. Now I'm coming to the wound debridement. There are several methods, and few methods are described here. The sharp debridement, wound irrigation, autolytic debridement, enzymatic debridement, maggots. I will take it one by one in detail. Sharp debridement means incision and excision. It is a sharp debridement. The sharp debridement is the most appropriate choice, but it causes pain. So it should be done in OT under anesthesia. It is better. But debridement will be successful when there will be proper perfusion of the tissue in the ulcer area. Irrigation of ulcer, it is another method. We irrigate the ulcer to slough out, to clean the slough from the floor. The sterile saline is the most common solution used for irrigation. Clean tap water can be just as effective. There is no need of adding some antiseptic. तो कोई जरूरत नहीं है कि इसके अंदर एंटीसेप्टिक ही डाला. Plain water से you can irrigate. तो ये एक तरीका और है debridement का. Autolytic debridement. Body's own proteolytic enzymes within wound fluid help break down the devitalization tissue. तो अपने जिस्म के अंदर कुछ ऐसे एंजाइम्स हैं, प्रोटीलाइटिक एंजाइम्स हैं जो जगह पे अल्सर पे काम करते हैं और डिब्राइडमेंट का काम करते हैं, बट इट इज वेरी स्लो डिब्राइडमेंट, causes separation of necrotic tissue from the healthy wound bed. It takes time. तो इसमें टाइम ज्यादा लेता है, टाइम कंज्यूमिंग है. सबसे बेस्ट होता है कि एक्ससीजन कर दिया जाए, वो शार्प डिब्राइडमेंट. एंजाइमेटिक डिब्राइडमेंट, application of collagen, papain, or raw crushed papaya to wound. It causes slow debridement, enzymatic debridement. You can see here it is a wound, ulcer, and chronic non-healing ulcer. And we have applied crushed papaya as a debridement agent. This is enzymatic debridement, effective in ulcer with minimal necrosis. Selective diagnosis, selectively digest protein in non-viable tissue and separates the healthy granulation tissue challenges in an enzyme isolated. They are collagenase are enzymes isolated from Clostridium histolytica. Hydrogen peroxide may interactive and may cause inactive पापेन. तो पापेन की मौजूदगी में, यानी पापेन का जब इस्तेमाल करें या पापाया का इस्तेमाल करें, हाइड्रोजन पेरोक्साइड को इस्तेमाल ना करें क्योंकि इसके फंक्शन को स्लो डाउन कर देता है. Medical maggots are also used as a debridement agent. The maggot secretes proteolytic enzyme which break down necrotic tissue, then ingested by the larva, leaving behind healthy tissue. तो जो भी dead tissues है उसे ingest कर लेता है. तो ये एक और तरीका है जिससे हम इस्तेमाल करते हैं, बट इन सोसाइटी इट इज डिसएग्रीएबल, पेशेंट अलाउ नहीं करता. मैगट थेरेपी इन एडिशन टू कन्वेंशनल वुंड केयर रिजल्ट इन मोर कंप्लीट डिब्राइडमेंट. तो दीज आर द डिब्राइडमेंट प्रोसीजर्स एंड वी कैन डिब्राइड द वुंड आल्सो बाय दिस मेथड. ड्रेसिंग, देयर आर सेवरल टाइप ऑफ ड्रेसिंग. And the cotton dressing is the most common and cheap and best, cheap but traumatic dressing. Allows wound infected, all wounds पे इसका इस्तेमाल कर सकते हैं, infected wounds पे भी, wound packing के लिए भी इस्तेमाल कर सकते हैं. Disadvantages क्या? There are frequent changes, आपको daily change करना होता है. It is the problem for this. Non-selective debridement, नो मॉइस्ट वुंड healing. इसमें मॉइस्ट वुंड healing का जो पर्पस है वो नहीं हल होता क्योंकि ये ड्राई होती है और जब इसे उठाते हैं, फाड़ते हैं तो ये कुछ हेल्दी टिश्यूज को भी ट्रॉमा पहुंचाता है, पेन भी करता है. Impregnated gauze dressing. Impregnated gauze में fine mesh gauze impregnated with petroleum, paraffin, wax or antibiotic ointment जो हम बैक्टी ग्रास के नाम पे इस्तेमाल करते हैं या दूसरे नामों से इस्तेमाल करते हैं, क्यूटिसेल के नाम से आया था. तो ये इम्प्रेग्नेटेड है. एडवांटेजेस है नॉन एडहरिंग, इनएक्सपेंसिव, वाइडली अवेलेबल, so you can use it. And disadvantage, no exudate control. Exudate control नहीं करते, no moist. Transparent film dressing. There are sheets of self-adhesive occlusive dressing. Transparency allows visualization of the wound. आप देख सकते हैं इस wound को कि इसके अंदर क्या चेंजेस आ रही हैं. एक बार लगा दिया तो ये डेली चेंज नहीं की जाती, बल्कि इसके अंदर जब एक बार हो गया तो उसको बाहर से wound के जो भी कैरेक्टरिस्टिक हैं उसे देखा जा सकता है. Benefits क्या? Both primary or secondary dressing allows oxygen to enter into the wound, allows moisture vapor to escape. तो बहुत अच्छे ड्रेसिंग है इस हिसाब से देखा जाए तो. Used in partial thickness ulcer, wounds such as donor site, superficial wound, and skin grafting. Foam dressing. Foam dressing, it is of two types, self-adhesive dressing, secondary adhesive. दो तरह की होती है, एक तो खुद ही चिपक जाती है पूरे तौर से, या एक होती है कि जिसमें सिर्फ पैड सा बना हुआ आता है, उसको रख करके ऊपर से फिल्म चिपकाई जाती है. Absorb fluid, moisture control. फ्लूइड को एब्जॉर्ब करती है, ज्यादा से ज्यादा एब्जॉर्ब करती है. मॉडरेट टू हाई एक्सूडिंग वुंड में इसका इस्तेमाल होता है. जो जिसके अंदर एक्सूडेट्स ज्यादा बनते हैं उनमें इसका इस्तेमाल है फोम ड्रेसिंग का. स्ट्रिप्स आर रिबन्स फॉर पैकिंग. एडवांटेजेस, सॉफ्ट कंफर्टेबल, नॉन एडरेंट. Or disadvantages, the slide behind the
behind the screen.
behind this,
Outside the screen, sir.
outside the screen. Oh.
Mhm.
Alginate dressing. Alginate dressing made from calcium alginate. It's a algae. इसको तैयार किया जाता है. Alginate dressing comes in various forms. Highly absorbent characteristic, effective control of exudates, maintaining a moist wound bed. So this dressing alginate is required in case of dry. It is used for packing deeper wound. गहरे wound होते हैं जो penetrating wound और punctured wound है, कोई sinus ऐसा wound है, उनमें होता है. Wound with tunnel, उसमें इस्तेमाल कर सकते हैं. Non-adherent, washable, and minimum pain to the patient, क्योंकि ये चिपकी नहीं चिपकती, इसलिए इसका इस्तेमाल हो सकता है. Don't use in dry or low evidence wound, lower ending. Hydrocolloids dressing, made up of colloid particles, better for moderate exuding wounds, impermeable to water, trapped wound fluid, promotes moist wound healing, impermeable to bacteria. And used for burn, pressure ulcer, venous ulcer. These are different type of the dressing we use accordingly. Hydrogels, it is another dressing. We are holding a large amount of water composed of more than 90% water. इसका better effect है कि it causes cool sensation at the site. Absorb or donate water depending on the hydration state of the surrounding tissues. जैसी requirement होती है वैसा ही करता है. जहाँ dry होगा वहाँ hydrate कर देगा. अगर वहाँ पे कुछ इस तरह की चीज है कि स्लफ है तो उसे absorb करेगा. Used for dry or dehydrated ulcer, cooling sensation provide pain relief. बहुत अच्छा result आता है इसका. High risk of bacterial infection, लेकिन chance इसमें bacterial infection के ज़्यादा होते हैं. This is a table accordingly, and wound dressing किस तरह की क्या characteristic हैं उनके, कैसे ये काम करती हैं, इसके indications, advantages and disadvantages. I am not going in detail for that. Leaching, medicinal leeches, Rhodomedicinalis have been used for bloodletting, wound healing, stimulating blood flow. तो ये बहुत अच्छा इसका रिजल्ट होता है जो हम अपने हॉस्पिटल्स वगैरह में इसका इस्तेमाल करते हैं chronic non-healing wounds के लिए. The leaching in venous ulcer, and before and after, you can see the result, the leaching. And here a case of post-compartment syndrome gangrene, right arm. Before it was referred case to the AIMS, and after that came to our hospital. He is a very poor patient, and he was treated in Mujahideen Hospital. You can see after leaching and papaya dressing. I have not shown the slide here of the papaya dressing. Papaya also used papaya dressing for the enzymatic debridement. And in this case, you can see the prognosis, the result of that leaching and papaya dressing also. Topical antimicrobial agents, these include iodine-based agents, silver-based agents, medical grade honey. ये दो के दोनों toxic हैं bacteria के लिए, they will cause toxicity and they are act as an antimicrobial agent. सिर्फ dressing और debridement से काम नहीं होता because there is a nutritional deficiency also, though, so you have it to the nutritional support. Protein deficiency is common in patient with pressure ulcer due to fluid discharge and comorbidity. Protein supplement required in these cases, so you have to give the protein as per the requirement. Use of multi-nutrient supplement, zinc, arginine, vitamin C, they will facilitate the faster wound size reduction. So they will be well nutrited patient. Glycemic control is a very important in case of diabetic ulcer and in normal also. In case of stress, there is usually increase blood glucose level, so you have to control that. Glycemic control is widely recommended to optimize wound healing, minimize the infection. Adjunct therapy, negative pressure wound therapy also can be used here to accelerate granulation tissue. It is excellent for preparation of wound bed for skin grafting, improves healing time in patient with diabetic foot ulcer, minimum hospitalization, no daily dressing. So it is better, you can use adjunct as an adjunct therapy, negative pressure wound therapy. This is a picture where an ulcer is treated by the negative pressure wound therapy system. Hyperbaric oxygen therapy also is VO2 used to speed up healing of wound, angiogenesis, carbon monoxide poisoning and gangrene. इनमें भी इसका इस्तेमाल होता है, but we are here focusing on the ulcer. Infection in which tissue are starved, इसमें भी इस्तेमाल होता है, but to speed up healing of the wound. In this case, we use benefits. Increase oxygenation to the body tissue, increase blood flow and circulation, boost white cell blood corpuscles, enhances the effectiveness of antibiotic, reduce swelling. These are the functions and benefits of the hyperbaric oxygen, but it requires a system, a unit in which the patient is kept and hyperbaric oxygen is given, oxygen concentration. But here up to the 5-year age, we give the 10 and pressure, and above 5-year age, more than 10 up to 20 or 30. Delayed wound closure, operative management. Operative management for an ulcer, इन सारी चीजों का करने के बाद भी आपको लग रहा है कि ट्रीटमेंट नहीं हो पा रहा, कंजर्वेटिव ट्रीटमेंट से फायदा नहीं हो रहा, then you have to go through wound closure, delayed wound closure. Delayed wound closure also minimize the duration of healing. तो non-healing ulcer, delayed wound closure करना चाहिए. First of all, you have to assess the etiology of the chronic wound. Assure before delayed closure, free from infection it should be, free from necrotic tissue, adequately profuse closure with minimum tension. Tension नहीं होना चाहिए जहाँ पे closure कर रहे हैं, लेकिन ये minimize उसी वक्त किया जाता है जब granulation tissues आ जाए और छोटा wound हो, बहुत बड़ा wound होगा तो उसमें problem आएगी. क्योंकि टेंशन सूचर पे होगा और दैट विल कॉज अगेन ischemia. Split thickness skin graft can be used for this purpose for the skin grafting. The split thickness skin graft from epidermis and part of dermis, we take it, and the range, it is harvested by a dermatomes and can range from 0.008 to 0.012 inches इतनी thickness. इतनी थिकनेस का ग्राफ्ट लेना चाहिए, मोटा ग्राफ्ट नहीं ले सकते. ग्राफ्ट इज यूजुअली मेश टू अलाउ एक्सपेंशन ओवर अ लार्ज एरिया. मेशिंग की जाएगी, मेशिंग करने के बाद उसका इस्तेमाल करते. mesh ratio can range from 1:1 and 1:6 depending on the need of the recipient site. So split thicknesses, there are very effective, very common way of the closure of the ulcer. Here are some pictures. Split thicknesses can graft before and after. The age is before, just after application of the mesh, and after healing, after 6 months, the same site you can see the healed graft. Full thicknesses can graft contains epidermis, entire dermis. But इसमें problem ये है कि full thicknesses graft, we can limited area we can take it because the donor area also required closure and it is very difficult. But in split thicknesses graft, there is no need to close the the recipient sites have to be rich in granulation tissue, usually harvested from the groin, lateral thigh, lower abdomen and chest. इनसे लिया जा सकता. Graft should be small and to manage the donor side, जो मैंने आपको पहले भी बताया कि avoid air, foreign body, necrosed tissue between graft and wound because it will interfere the adhesion or healing. These were all about the non-healing ulcer, but because of shortage of time and there was different disturbance in the net, so I fastened the slide and that is, thank you and Jazakallah for the watching.
Thank you, Minaj sir. Thank you for your valuable speech, valuable talk. Dear participants, our speaker is with us. If you have any query, you can ask directly, one by one. Hello.
Anybody has a question?
Okay, let us go ahead. I think the things are clear. Everybody have understood the nature of the ulcers and the treatment. Sorry for the interruption in between. It was a technical problem, and I may correct myself that I told that Dr. Minhaj is Deputy Medical Superintendent. I'm sorry, he is Medical Superintendent of the Mujidia Hospital right now. He nicely elaborated the etiology, examination, treatment, and management of the non-healing ulcer. And he also shared his experiences with us. Thank you, sir. Thank you very much.
Thank you.
Thank you very much. I'm glad to share with you, with participants, that we have some overseas participation today from Sri Lanka. Almost 20 people have joined from Sri Lanka in this session. I welcome you, sir, all participants from overseas, from Sri Lanka, in this one-day national webinar. Now, moving ahead, we have now next speaker, and the topic is quite interesting and a common problem in Indian population, and particularly here in Bangalore, we have a good number of patients, particularly in proctological cases we receive. And among them, we have a good number of hemorrhoids, hemorrhoidal cases, which we come across daily in our OPD. So our next topic is hemorrhoids and its management. The lecture will be delivered by Dr. Mahjabeen Fatima, who is Senior Assistant Professor, Department of Jarahat, NIUM, Bangalore. She also did her BMS and MS from Ajmal Khan Tibia College, AMU Aligarh. Soon after completing her master's from Department of Jarahat, Ajmal Khan Tibia College, she joined there as faculty member in 2013. Then in 2014, she joined Department of Jarahat, Ilmul Jarahat, NIUM, Bangalore. She had also worked as SR in short-term project of CCRM. She has around 20 publications in national and international journals. She has attended and presented papers in 40 national and international conferences and seminars. This honest lady is also a good teacher, a good surgeon, and always remains on forefront in completing any given task. In fact, she has played a major role in organizing these webinars. Over to Dr. Mahjabeen Fatima. Madam, please go ahead.
Thank you very much, Dr. Firdaus. I appreciate the kind introduction. Respected Director NIUM, Professor Abdul Wadood sir, our HOD Professor Syed Shah Alam sir, Dr. Minaj Ahmed, Associate Professor Jamia Hamdard, my colleagues, teachers, and dear participants. Assalamu alaikum. First of all, I thank to our Director Professor Abdul Wadood sir for providing this platform. Also, I would like to thank my HOD Professor Syed Shah Alam sir for giving me this opportunity. Dear participants, my topic of presentation today is hemorrhoids and its management. Hemorrhoids and its management. First of all, introduction. Hemorrhoids or piles, they are one of the most common anorectal diseases of mankind. It is derived from two Greek words, hema means blood and rous means flowing, and it is probably given by Hippocrates. Pile has been derived from Latin word pila, which means a ball, and in French it is also called a spig. Hemorrhoids are swollen and inflamed veins around anus or in the lower rectum. Here is the diagram. You can see these are inflamed hemorrhoids. Hemorrhoids, they are enlarged veins. They are located within the tissues of the lower portion of the rectum or anal canal. 50% of the population will experience symptomatic hemorrhoids at some time in their lives. The peak incidence between the age group of 45 to 65 years. Hemorrhoids before the age of 20 is unusual. The risk is higher for whites than for blacks. It is the most common cause of lower GI bleeding, and its frequency in India is 30 to 40%. As per Unani literature of medicine, in Unani system of medicine, hemorrhoids are known as bawasir. Bawasir is the plural form of basur, which means warts or polyp-like swelling. It is an excessive growth at the mouth of the vessels present in anus, which is due to accumulation of ghalis filth soda. Hippocrates, according to him, bawasir is the swollen vein of the internal mucous membrane of the rectum. According to Ali ibn Abbas Majusi and Abu Marwan ibn Zuhur, bawasir is the growth or swelling at the end of the vessels of the rectum. According to Ibn Hubal Baghdadi, he described that the formation of bawasir indicates that the morbid viscid humor, ghalis akhlat, they are present in the body and they led to the formation of the hemorrhoids. Ibn Sina conceptualized that the morbid material of hemorrhoids is filth soda, but it may also arise from filth balgam. Samarkandi, according to him, prime cause of Babasir is viscid Saudavi blood, resulting in the warty swelling at the end of the rectum. Hakim Azam Khan, according to him, Babasir is the swelling at the end of the rectal vessels due to accumulation of Saudavi blood. Now we come to the pathophysiology. According to the conventional system of medicine, there is his sphincter hypertonicity, anal cushion hypertension, or deterioration of connective supportive tissue. It will lead to abnormally high anal pressure. It will lead to increased straining during defecation, venous drainage impairment, increased cushion pressure causing stress on supporting connective tissue or mesh, and increased congestion and slippage of the anal cushions leading to hemorrhoids. Now, according to Unani system of medicine, the pathophysiology of hemorrhoids is the morbid filth soda, which starts to precipitate in the liver and pushes towards the anorectal vessels, where it accumulates and leads to the formation of the hemorrhoids. Now we come to the etiology. According to the conventional system of medicine, the causes are erect posture of the mankind, irregular bowel habits, constipation or diarrhea, a low fiber diet, increased intra-abdominal pressure, prolonged straining, and intra-abdominal mass of pregnancy, absence of valves within the hemorrhoidal veins, aging, alcoholic cirrhosis, or other causes of portal obstruction, which can lead to severe hemorrhoids. Other factors, they are obesity, prolonged sitting, chronic cough, pelvic floor dysfunction, chronic diarrhea, irritable bowel syndrome, and it can be familial also. According to Unani system of medicine, most common cause of hemorrhoids is filth soda. Due to consumption of drugs which are hot in temperament and due to safra, when it mixes with the blood becomes soaked, that means burnt, and galiz, viscous akhlata formed. Galiz, the viscous blood that develops due to the excessive consumption of Saudavi substances. Persons living in the areas where the air is ratab, moist, and mutafan, purified, and in those persons who consume more dates, milk, and fish. Persons having Saudavi temperament, accumulation of excess filth balgam, sedentary lifestyle, avoidance of exercise, long hour sitting professions, taking excessive red chilies, non-vegetarian foods, and spicy or oily foods, excessive alcohol intake, and frequent use of purgatives. Now, clinical features of hemorrhoids. Hemorrhoids or piles, they are symptomatic anal cushions. They are more common when intra-abdominal pressure is raised. Example is obesity, constipation, and pregnancy. Classically, they occur in 3, 7, and 11 o'clock positions, the patient in the lithotomy position, and they can also be present in secondary positions also, besides these primary positions. Symptoms of hemorrhoids, there is bright red, painless bleeding, and it is the principal and earliest symptom. Initially, the bleeding is slight. It is bright red and occurs during defecation, like a splash in the pan. Blood is not mixed with the stools. It is small in amount, but occasionally heavy bleeding may occur. And in hemorrhoids, there is dripping and squirting nature of bleeding. At the time of defecation, and it highly suggests that it is because of hemorrhoids. Mucous discharge can be there. There can be prolapse, and pain, usually they are painless, but pain can occur when these hemorrhoids are prolapsed. Now, classification of hemorrhoids. According to conventional system of medicine, they are divided into 3 types: external, internal, and intra-external hemorrhoids. External hemorrhoids, they are located in the distal 1/3 of the anal canal, distal to the dentate line, and are covered by aneurysm. Internal hemorrhoids, they are located proximal to the dentate line and are covered by columnar or transitional epithelium. Because this overlying tissue is viscerally innervated, it is not sensitive to touch, pain, or temperature. Intro-external hemorrhoids are also called mixed or combined hemorrhoids, and there is presence of both internal and external hemorrhoid component is there. In the figure, you can see this. This one is the internal hemorrhoid, and this is external hemorrhoids. And sometimes internal hemorrhoids and external hemorrhoids, they are present in continuation, so they are called as intra-external hemorrhoids. 4 degrees of hemorrhoids are there. First degree, bleed only, no prolapse is there. Second degree, prolapse but reduces spontaneously. Third degree, prolapse and have to be manually reduced. Fourth degree, permanently, they are permanently prolapsed. Here in the diagram, you can see these are the 4 clinical grades of hemorrhoids. First degree, no prolapse, just prominent blood vessels are there. Second degree, prolapse emerges with the strain but spontaneously reduces and returns by itself. Third degree, prolapse emerges with the strain and needs to be pushed back in. That means manipulation is needed here. Fourth degree, prolapse emerges and cannot be reduced or pushed inside. According to the Unani system of medicine, they are also divided into many types. According to the shape of the mass, it can be soluli like boards, inabi like grapes, tuti like mulberry. According to bleeding, it can be damia or umia. Damia hemorrhoids with bleeding, they are also called as babasira puni. Hemorrhoids, umia is hemorrhoids without bleeding, it is also called as babasira rihi. And according to the site of appearance or location, it can be nabita, gaira, and darmiani. Nabita is external hemorrhoids, gaira is internal hemorrhoids, and darmiani is intra-external hemorrhoids. Diagnosis. How we are going to diagnose hemorrhoids? They can be diagnosed with inspection if they are external. Inspection, a visual examination of anus may be enough to diagnose hemorrhoids. Then we can go for digital rectal examination. Examiner inserts a gloved finger, lubricated finger into the rectum to feel for swollen veins. We can go for proctoscopy also. A proctoscopy, also called as rigid sigmoidoscopy. This is a procedure to examine the inside of the rectum and the anal canal. It is usually done to look for tumors, polyps, inflammation, bleeding, and hemorrhoids. We can also go for colonoscopy. After sedation with medicine, a thin flexible tube called a colonoscope is inserted to look at the inner lining of the colon. Colonoscopy can help to discover ulcers, polyps, tumors, and other areas of inflammation and or bleeding and hemorrhoids. Sigmoidoscopy, this procedure is similar to a colonoscopy, but it uses a shorter tube called a sigmoidoscope to examine the lining of the rectum and the sigmoid colon. Now we come to the differential diagnosis. It has to be done with the skin tags. Sometimes hemorrhoids are confused with the skin tags. There is a small growth in the rectal region and it is typically harmless. Anal fissures, if symptoms are accompanied by pain, there is a good chance that they are caused by anal fissures, not hemorrhoids. Because usually hemorrhoids are painless unless there is some complication there. These are small skin tears that often result from troublesome bowel movements such as constipation or diarrhea. Like hemorrhoids, anal fissures can cause rectal region to itch and bleed. Anal abscesses. These are pockets of infection in the anal region. Can sometimes be confused with hemorrhoids because both can cause swollen lumps. However, an abscess is the result of an infected gland. The infection causes the tissue to swell and become filled with pus. Unlike many hemorrhoids, abscess can be painful. Anal fistula. Anal fistulas are unnatural tracts that lead through rectal tissue to the outer layer of skin, and they are often associated with anal abscesses. Anal fistulas may be mistaken for hemorrhoids because of pus or blood discharge. Genital warts, these are growths caused by human papillomavirus. In hemorrhoids, swollen mass is present in rectal region. Although genital warts don't usually cause pain, they may itch or bleed. Tumors in the colon, rectum, or anus can mimic symptoms of hemorrhoids. Sometimes these tumors are benign, but they can also be malignant. Therefore, proper diagnosis is necessary here. Inflammatory bowel disease, ulcerative colitis, Crohn's disease, and other inflammatory bowel issues can mimic symptoms of hemorrhoids. These diseases causes ulceration in the colorectal system. Other symptoms include pain and bleeding. Irritable bowel disease symptoms can mimic hemorrhoids. IBD can also contribute to hemorrhoids. It can also lead to hemorrhoids. Now we come to the treatment portion. How we are going to treat hemorrhoids. First of all, conservative options are there. If grade 1 and 2nd internal non-thrombosed or non-thrombosed external hemorrhoids are there, then we can go for high fiber diet, more fluid intake, SITS path. We can give stool softeners, topical or systemic analgesics can be used, and proper anal hygiene has to be maintained. And we can also give short-term topical steroids. In non-surgical options, indications are recalcitrant hemorrhoids. Here we can go for rubber band ligation, infrared coagulation, injection sclerotherapy, laser therapy, and cryosurgery. Surgical management, non-surgical treatment, if we are going for this conservative treatment and non-surgical options and patient is not getting any relief, then or if grade 3rd and 4th internal with hemorrhoids with severe symptoms are there, then we have to go for surgical management. In this, 5 to 10% eventually requires surgery, and we have to go for hemorrhoidectomy. Or some home remedies to cure hemorrhoids. Suppose we can use this black cumin seed paste to get rid of hemorrhoids. Bananas, they can act as laxatives. Radish, it reduces inflammation due to piles. Bitter gourd juice, it prevents piles. And figs, they ease in bowel movement. And buttermilk, it is going to cure bleeding piles. Now we come to the non-operative measures. These procedures, they are usually done on OPD basis. First one is this sclerotherapy. This was first described by Morgan in Dublin in 1869, mostly used for first and second degree hemorrhoids. A submucosal injection of 5 ml of 5% phenol in almond oil or 5% quinine and urea or hypertonic 23.4% salt solution can be used. Here at the base of the hemorrhoid, we have to put this sclerosant agent. It is injected in the submucosa at the base of the hemorrhoid, causing thrombosis of the vessels, sclerosis, and shrinkage of connective tissues and overlying mucosa. It takes only few minutes to perform. It is less invasive and less painful procedure. It is a successful OPD procedure, but might need repeated settings. And adverse effect of this therapy is heavy bleeding, sepsis, and prostatitis. Second procedure is rubber band ligation. This was originally described by Barron in 1963. It is mostly used for second degree internal hemorrhoids. The rubber band is placed on internal pile mass a minimum of 2 centimeters above the dentate line, which causes strangulation of the blood supply to the banded tissue, and the mass sloughs off in 5 to 7 days. Here, first of all, we have to hold this pile mass. Then at the base of the hemorrhoid, we have to put bands. Not more than 2 piles should be banded at same sitting, and at least 3 weeks should elapse between each sitting. Third one is this cryotherapy. It is based on the principle that freezing the internal hemorrhoids at low temperature can lead to tissue necrosis. A special probe is used through which nitrous oxide at minus 60 degrees centigrade to minus 80 degrees centigrade or liquid nitrogen at minus 196 degrees centigrade is circulated. Nowadays, it is not used commonly because the procedure is time consuming and associated with a foul smelling, profuse discharge, irritation, and pain after the procedure. Now, transanal hemorrhoidal dearterialization. This procedure uses the kit with an anoscope that reaches the upper portion of the lower rectum, where a Doppler device locates the terminal branches of the hemorrhoidal arteries 6 to 7 centimeters from the anal margin at the rectal circumference. These vessels are ligated, direction up to the lower Doppler signal 2 centimeters from the anal margin above the dentate line. The lower portion of the suture ligation is tied to the upper portion, performing a mucopexy with prolapse reduction. The procedure may be indicated for patients with bleeding second, third, or fourth degree hemorrhoids. Now, Doppler guided hemorrhoidal artery ligation. This technique for treating hemorrhoids was first described in 1995. It is performed using a specially designed proctoscope with an inbuilt Doppler probe that can locate feeding arteries. These vessels are then ligated using absorbable sutures. Disrupting the inflow to the vascular cushion is thought to reduce the size of the hemorrhoid. The technique is relatively painless with minimal morbidity, and up to 60% of patients in the larger studies are satisfied with the outcome. Further, randomized controlled trials are needed, but this offers a less mutilating alternative to surgical hemorrhoidectomy. Infrared photocoagulation. Infrared photocoagulation, it is also called as coagulation therapy. It is a medical procedure used to treat small and medium-sized hemorrhoids. This treatment is only for internal hemorrhoids. During the procedure, coagulation is carried out by focusing infrared radiation from a tungsten halogen lamp through a polymer probe tip. Heat created by the infrared light causes scar tissue which cuts off the blood supply to the hemorrhoid. The hemorrhoid shrinks and a scar forms on the wall of the anal canal. Only one hemorrhoid can be treated at a time. Other hemorrhoids may be treated at 10 to 14 days interval. This medical procedure may be done with other devices such as laser or electrical current that also cut off hemorrhoids' blood supply. Weightlifting and straining during defecation should be avoided until it heals. Direct current electrotherapy. It was first used in 1876 and explained by Wilbur E. Creasy in 1934. It is now considered as one of the recently used modalities. It requires up to 14 minutes application of 110 volt direct current to the base of the pile, well above the transition zone. The direct current has not been widely accepted due to its lengthy time and limited control of the high-grade prolapsing piles. Bipolar diathermy. Its principle is based on electrical energy, which is used to coagulate pile mass. This procedure consumes very high-frequency electric current. Underlying pile mass is coagulated by application of 1 second pulse of 20 watts. Each pile mass may require multiple application. The prolapsing tissue can be eliminated by it. Now we come to the operative measures. Surgical treatment is the initial option in the management of symptomatic 3rd or 4th degree hemorrhoids. In patients with acute hemorrhoids that have not improved with other therapies, hemorrhoidectomy. It is considered the gold standard. In this, Milligan-Morgan's and Ferguson's procedures are the most widely used techniques throughout the world. Closed hemorrhoidectomy. The Ferguson hemorrhoidectomy, it is also called as closed hemorrhoidectomy, is the most commonly used surgical technique. An elliptical incision is made in the external hemorrhoidal tissue extending proximally to the dentate line to the upper limit of hemorrhoids. One should take care to make a narrow ellipse and remove only the redundant anoderm and hemorrhoidal tissue. The wound is closed with continuous absorbable sutures. It is effective in 95% of cases. Now, open hemorrhoidectomy. The Milligan-Morgan technique, also called as open hemorrhoidectomy, it is also widely used. It involves excision of the external and internal hemorrhoid components, leaving the skin defects open to heal by secondary intention over a 4 to 8 week period. Now, stapled hemorrhoidectomy. This is a newer technique. In this, we are using a stapler. This technique uses a specific circular stapler to excise a circumferential ring of mucosa above the dentate line. The main characteristic of this procedure is less surgical wound, which makes the procedure potentially less painful than the conventional procedures. This technique is used in 3rd or 4th degree hemorrhoids as long as they are not too bulky. Now, these are the steps of stapled hemorrhoidectomy. First of all, this circular dilator. This is being secured with sutures and internal hemorrhoids, you can see. Then needle is being pushed, anoscope is being inserted, and needle is being pushed there. Persisting suturing is being taken, and the circular stapler. This persisting suturing is tightened, and then circular stapler is inserted, and stapler is being closed and fired. And through this mucosa donut has been removed, and this is a staple line you can see. Now, this is the suggested algorithm for the management of the hemorrhoids. Suppose patient presents to the practitioner with symptoms. First of all, assessment we have to do, and this we have to do with inspection and proctoscopy and other tests if required. And if there are non-prolapsing piles, then we have to give fiber supplements to the patients and some dietary changes we have to make. And if there are prolapsing piles, then we have to refer to the colorectal surgeon. And if they are 1st and 2nd degree, then we can go for this rubber band ligation and fiber supplements and dietary modifications. If it is 3rd degree, then rubber band ligation and the fiber supplements can also be given. And if it is 4th degree, then surgical hemorrhoidectomy we have to go for. It can be either open, closed, or stapled hemorrhoidectomy. Now, management of hemorrhoids according to Unani system of medicine. According to Unani system of medicine, first and foremost thing is the izala sabab. That means elimination of the cause. Whatever is the cause, it should be promptly eliminated. Since the main cause for the development of hemorrhoids is Saudavi or Ghaliz khun, so tanqiya of this morbid matter from the body with the help of different procedures is done, and its formation in the body should also be avoided. For the tankia of morbid matter from the body, the following procedures are helpful. First, venesection. First of rage basilic vein, and in severe conditions, first of rage saphenous veins along with rage basilic is done. Hijama, cupping on barican, that means on buttocks, it is done, or on ossus coccyx, it can be done. Talik, leeching, directly applied over the hemorrhoidal swelling or adjacent to it, due to which the morbid matter lodged in the hemorrhoidal plexus directly expelled out from the affected area. Ishal purgation, it can be done with the help of mucilate soda drugs like Aptimum, Farbach, Thalilasya. Other methods which can be used for the treatment of hemorrhoids include correction of liver, intestine, stomach, and spleen, because hemorrhoids can never form without sui misage of these organs. Exercise like brisk walk and use of hammam to dissolve the morbid matter is also helpful. Drugs used in the treatment of hemorrhoids should have properties like hyposutta, hemostatic, mulayyan, laxative, mundamil, healing, and musakkin alam, analgesic, and mufatta. That means deobstruent and akal corrosive. In bleeding hemorrhoids, following combination of drugs may be used, like Geru, Pohorba Shamai, Bust Ahmad. Powder of these drugs is used with Sharbate Anar 20 ml. For local soothing effect, marham ointment is applied, which is prepared from following drugs: Safeda, Kalai, Mom Safeda, and Doganidul. Now we come to the surgical techniques which are being used in Unani system of medicine. They are called as Amale Dastkari. This is excision of pile mass and then cautery. Excision of pile mass and then suturing of raw area. Ligation of the base of the pile mass, following which the mass sheds off, and application of akal corrosive medicines over the pile mass. Classical surgical procedures. These are Amale Khazam. Needle attached with silk thread is inserted at the base of the pile mass, and the thread is tied 2 to 3 times circumferentially. The knot is made and the thread is kept as such. After a few days, the mass dries off and sheds along with the thread. Amale Shad. Pile mass is dragged out with the help of forceps. The base is visualized and tied with thread. Forceps are also called as sunar. Thread is kept as such, and on second day it is tied again tightly till the mass sheds off. Amale Kata. Pile mass is dragged with forceps or with dry rough cloth. When the pile mass prolapses completely, it is tied at base and is excised. Then hemostatic medicines are sprinkled over the raw area. When 2 or more pile masses are there, one is left as such to avoid complications. Now, complications can be blood clots in the swollen veins can be there, leading to thrombosed pile mass. Bleeding can be there, profuse bleeding can be there. And because of this profuse bleeding, iron deficiency anemia can occur, and infection of external hemorrhoids or ulceration can also occur. Now, conclusion is hemorrhoids, they are common anorectal disorder worldwide. As in case of every disease, prevention is the best treatment, and here it is also applied. Most of the patients can be effectively treated with diet and lifestyle modifications only. Avoidance of constipation is the key in treating hemorrhoids. Non-operative treatment methods are used for the patients with the first, second, and third degree hemorrhoids. Surgery is indicated in patients with acute complications or those in whom conservative treatment has failed. Many surgical and non-surgical treatments are also available in Unani system of medicine. Non-surgical techniques, which includes first, hijama and talik, are also beneficial in treating the hemorrhoids and may prove to be the best and cheap alternative. Moreover, the conventional surgical techniques used nowadays are only the modification of already described procedures in Unani literature. The main aim of the presentation is to highlight contribution of Unani physicians as well as surgeons in treating this common ailment conservatively, non-surgically, and surgically. Take home message. Hemorrhoids are enlarged vesicular cushions in the anal canal. Treatment depends on the degree of prolapse and severity of symptoms. Rubber band ligation is the best outpatient for hemorrhoids. Up to 80% of patients are satisfied with short-term outcome. Surgery is reserved for large symptomatic hemorrhoids that do not respond to outpatient treatment. Doppler-guided hemorrhoidal artery ligation and stable hemorrhoidopexy are new alternatives to the traditional and more painful open or closed hemorrhoids. hemorrhoidectomy. The other references. Thank you. You can contact me on this email address.
Thank you, madam. Any query? Participants, please, if you have any query, you can put forward. Madam is with us. Okay, thank you. Thank you for your nice presentation, madam.
Thank you.
You nicely explained the hemorrhoids and particularly the Unani perspective of the hemorrhoids. And as we have observed in our OPDs, madam, I may add that the main problem remains the diagnosis at when the patient lands in any proctological problem. Here in our Indian culture, most of the patients do not want to expose their pudenda, and the practitioners or doctors working on peripheries need some reorientation programs for diagnosis, for the examination of the proctological cases, so that they can diagnose the cases properly and manage them properly or refer them to the proper place. We have observed the main problem remains misdiagnosis until patient comes to us at a later stage when the surgery or the complications are inevitable. So we have observed that the early diagnosis will result in nice treatment either with conventional or Unani system of medicine. Overall, your presentation was very informative, and I hope it will help all the participants and the practitioners who are with us. So, dear participants, before moving ahead, I will request you all that you will receive a feedback form. Please fill up your feedback forms. After filling feedback forms, you will receive your e-certificates. So, both lectures are over now. I will now, this is time for vote of thanks who have joined us, and I will invite our colleague, Dr. Mohammad Shakil Ansari, to present vote of thanks. Dr. Mohammad Shakil Ansari.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.
First of all, my sincere thanks to Almighty Allah for making today's webinar a grand success. By His blessings and grace, we are able to make this one-day national webinar on Ilmul Jarahat updates 2022 successful. The warm greeting of the day to all of you. Honorable Director Professor Abdul Wadud sir, respected HOD Ilmul Jarahat, NIUM Professor Shalan sir, and respected speakers, Dr. Minal Ahmed sir and Dr. Mahbin Fatima, and respected participants of this webinar. On behalf of Department of Ilmul Jarahat, NIUM Bangalore, it is my privilege to propose a vote of thanks and acknowledge the contribution of those who worked hard to make this national webinar a grand success. I give a heartfelt vote of thanks to Director NIUM Professor Abdul Wadud Sahab for his valuable support in organizing this webinar, and to our HOD Professor Sayyid Shalan Sahab for the support and encouragement in organizing this webinar. It is my privilege to offer thanks and to extend my heartfelt gratitude to our esteemed speakers. Thanks to the speakers for adorning the occasion and sharing the opinions and views today. I would like to express our sincere thanks to Dr. Minhaj Ahmed Sahab, my senior also, for giving excellent coverage to the topic non-healing ulcer and their management, and for sharing his findings and opinions. I am also very grateful to Dr. Mahbin Fatima for analyzing and sharing her opinions and views on the topic hemorrhoids and their management. Sincere thanks to the convener of this webinar, Dr. Firdaus Ahmad Najar, for the smooth conduction of the event, and the IT cell of NIUM who handled the event throughout. A wide round of applause and thanks to all respected participants from all over the India who made the event memorable. Finally, I would like to thank all of you present here for making the time to be with us today and helping us to make this event a grand success. Thank you one and all. Jazakallahu khairan.
Thank you, Dr. Mohammad Shakil, sir. Thank you. And I'm also thankful for the overseas participants who have joined us without any invitation, they have joined us. And inshallah, we will be back with our next webinar in next month. So till then, stay tuned, stay blessed. Allah Hafiz.
Thank you.
Thank you to all.